There are two types of motor speech disorders, dysarthria and apraxia. We will be focusing on dysarthria today. A unique thing about motor speech disorders or dysarthria are that even though they are not able to produce speech because of motor planning problems, does not mean that their cognition is affected. Most of the time, their cognition is intact and the function of speaking is the only problem with their speech. This is a myth because, as we know, their cognition is not affected. Even though they cannot produce speech, does not mean they cannot understand it.
As adults get older, they possess a greater risk of acquiring one of the following conditions, which can be a contributing factor to a motor speech disorder, as each can affect the brain, which is essential in a person's ability when using their facial muscles required for speech. This is a myth, as individuals with a motor speech disorder may seek treatment options that can help them regain effective speech. For an individual with dysarthria, for example, treatment approaches focus on exercising that helps regain the patient's muscle strength and may also include altering their rate of speech, either by increasing their speech or by having them slow down their speech.
When interacting with someone who has a motor speech disorder, you may notice that they have a slurred or slow rate of speech. They also may display a struggle in the ability to place the tongue, the lip, and the jaw in a smooth sequence while they talk. These people may also have involuntary movements of their facial muscles, such as an eye twitch, or they may not be able to sit still because they can't control their muscles. Another thing you may notice, other than during a conversation, would be their reflexes. Someone who has a motor speech disorder, they may have an increased or reduced reflexes. So, in order to test these reflexes, an easy way that clinicians can test it would be to put their finger in front of their face really quickly and to see when they blink. So, an example would be the clinician would take their finger and go really quickly in front of the subject's face, and usually, um, when something is coming at you, you blink. So, they would be looking for that. Lastly, when testing an individual, they would be asked to say as long as they can. So sometimes people with motor speech disorders may not be able to do this as stable, and it might sound like uh. This is a myth. Speech disorders are not caught like the common cold, as we might think. Speech disorders may run in families through genetics, though they are not a contagious illness.
As SLPs, our main objective is to facilitate communication. When looking at motor speech disorders, we start out by looking at speech intelligibility. Is the communication partner able to understand what the patient is saying? Respiration. Do they have enough breath to be able to produce a full utterance or full word? Sometimes we see in individuals with motor speech disorders, they have pauses in places that breath would not usually be taken. Phonation. Are they able to have enough breath that to go to their vocal folds to be able to produce a voiced sound, such as g? You use your air and it works with your vocal folds to then produce it. Is their voice really soft or really loud to see where their resonance is? And finally, articulation. Are they able to use their articulators, which for example could be the lips, to work together to produce a sound? So in the sound p, we see that our lips come together to restrict the air and then be able to produce that sound. In individuals with motor speech disorders, they may not be able to put their lips together at the correct time in order to produce that p sound. So p. SLPs can help in many ways depending on what's affected. For example, if their respiratory system is affected, the SLPs can work on breathing coordination to help them better phonate sounds.